Babita, and this evening we are going to hear three very eminent speakers talk about the concept of good death, a topic which is gaining a lot of attention and momentum in our country in the last few years. Chairing the session today with us, we have two very eminent and well-known members of palliative care community in India. Our chair for today are Dr. Stanley McCarran and Dr. Dinesh Chandra Goswami. And Dr. Stanley McCarran, I think he'll join us very shortly, is the national coordinator for CMAI for its palliative care program and is also an honorary consultant at Bangalore Baptist Hospital. But most important of all, he is the lead for Project India of International Collaborative for the Best Care of the Dying Person, University of Liverpool, UK. And so this topic is very much close to his heart. We have Dr. Dinesh Goswami, who's the founder secretary of Guwahati Pain and Palliative Care Society and a faculty of IAPC. He has been fundamental in establishing and growing palliative care in Assam and northeast of India. I would request Dr. Dinesh to go ahead and introduce our speakers for today. Dr. Dinesh? You are muted, sir.
Good evening, everyone. Can you hear me?
Yes, sir, you are audible.
Yeah. Good evening, everyone. We are going to have this very important session today. On we have eminent speakers, Professor John Ellershaw, and who is the first speaker, and he is now. I call him to give his lecture.
Welcome to this talk on best care for the dying person. My name is Professor John Ellershaw. I'm Professor of Palliative Medicine at the University of Liverpool, and I'm Chair of the International Collaborative for Best Care for the Dying Person. Today, I want to talk about the World Health Organization resolution, the International OpCare 9 Research Collaborative, and the International Collaborative for Best Care for the Dying Person. So firstly, the World Health Organization resolution, published in 2014, showed the global need for palliative care. 20 million people need end-of-life palliative care services each year. 42% of countries, however, have no palliative care services. 80% of the world's population lack access to medication, and 5.5 million cancer patients have no access to adequate pain treatment. So there is much to be done. So I want to talk to you now about an initiative, the International OpCare 9 Research Collaborative. This was an initiative, a European collaboration funded by the EU with the 9 countries you can see the flags of here. And this collaboration was to look at research for the care of cancer patients in the last days of life. The main themes of this were signs and symptoms of approaching death, end-of-life decisions, complementary comfort care, psychological and psychological support, and voluntary service. So encompassing key aspects of care for patients in the last days of life. One of the things that we developed from OpCare 9 was this model for research, but care for the dying is a discrete period of care of the last hours and days of life. But if we don't prepare people for that, then how and where they die can be influenced. And if people don't die well, then those that are left behind in bereavement can have a traumatic time. So even though our focus for this talk is around care for the dying, we need to know what comes before is important, and the quality of the care for the dying influences the experience of those left behind. From that initial project, a number of important papers were published, and it gave us a group of really engaged clinicians and researchers keen to further develop care for the dying. And that led to the creation of the International Collaborative for Best Care for the Dying. So made up of leading thinkers, practitioners and researchers from originally those 12 countries, but building on that to extend a collaborative working relationship across the globe. So it was formally established in 2013. And the vision of the International Collaborative is a world where all people experience a good death as part of an integral part of their individual life, supported by the very best personalised care. There are 10 key principles of care for the dying patient. I published this along with Maya Lakhani, who's chair of our National Palliative Care Council. This was published in the BMJ, and within it, these 10 key principles were highlighted. Firstly, that we need to recognise the patient is dying, that we communicate with the patient and always with the family and loved ones, that we provide spiritual care, anticipatory prescribing for common symptoms for dying patients, and that we review clinical interventions in the best interests of the patient. We review hydration, we review nutrition, and we have a full discussion of the care plan with the patient, if possible, if the patient is still awake and competent, and with the relative or carer. That's then followed by regular reassessment of the patient and a dignified and respectful care after death. So these 10 key principles underpin our thinking of best care for the dying patient, both in practice, but also for research. So at the centre of the International Collaborative, we have developed what we call the 10-40 model for best care for the dying patient. So the 10 stands for the 10 key principles, and underlying that are 40 core outcomes, which we advocate should be contained within a care plan or the plan of care that's evolved for a dying patient. This international model is continually updated and modified from our research and international development. It's also enhanced by learning and teaching, and quality assurance to deliver the optimum care for the dying is delivered. So that 10-40 model, which I'll mention again a little later, is something that a number of countries have taken forward to underpin and enhance their care for the dying. So what I want to talk about now, specifically about the International Collaborative, is the research that we've undertaken. A major piece of research was the ERINET-LAC code, quite an acronym, but this piece of research was between 4 European countries and 3 Latin American countries, looking at the evaluation of the code questionnaire of bereaved relatives and bereaved relatives' experience in these 7 countries. And out of that, some action learning sets were developed to improve specific aspects of care in the individual countries. This research program is being finalized, and key research articles are currently being published. Our current major international research collaborative is the ILIVE project, which I'm going to talk about in more detail. I'll then talk a bit more in depth about the 10-40 model and the quality improvement framework, and then a little bit more on the International Collaborative, its structure, and the programme of events. So the ILIVE project. This is an exciting project entitled Living Well, Dying Well. It was funded in 2020 by the EU Horizon funding of 4.5 million euro. And it's a collaboration between 13 countries led by Professor Agnes van der Heide of the Netherlands. Here is our kickoff meeting, which was in Rotterdam, and that was in just pre-COVID days. As you can see, the ambition is to recruit 2,000 patients to this study. I have to say that the challenges of COVID over the past 2 years have somewhat thwarted the recruitment of patients, but we hope with an extension of the study that we can still achieve this ambitious recruitment. There are different aspects of the study: a cohort study, which is the large number of recruits, but also an embedded medication study and volunteer study. So the cohort study includes 10 countries and is there around an international empirical framework to study patients, families and caregivers' experience with dying and bereavement. and to deliver an in-depth understanding of the concerns, expectations and preferences of dying patients and their formal and informal caregivers. Embedded within the cohort study is a medication studies in 3 countries and a development of a novel clinical tool integrated into electronic medical systems. This is to optimize medication management, to improve the use of beneficial medication and avoid the use of non-beneficial medication. The volunteer study includes 5 countries and is involved in the development and implementation of a volunteer training program to support dying patients and their families in the hospital setting. The evaluation of impact upon patients' quality of life in the dying phase and family bereavement. Here is an overview of the work package structure. I'm not going to go into this in great detail, but for each of these work packages, there are key milestones and deliverables within the research program. So we're very excited by this new international collaborative research and really puts the international collaborative at the forefront of research for care for the dying. The expected impacts of the project are to reduce symptom burden and suffering, improve clinical guidelines and policy, and reduce economic and wider societal burden, and improved quality, effectiveness and cost effectiveness of end-of-life care services. So moving on, the 1040 model and quality improvement framework has, as I said previously, been developed from the 10 key principles and 40 core outcomes. And this is developed into clinical documentation, which helps support and guide the clinical care for dying patients. Here you see a number of documents that have been developed, including Spain, including Norway, including Australia, including India. And these programs are running in a number of countries around the globe. Underpinning the quality improvement framework is a 10-step implementation process. And this is supported by tools and documents and resources. This is one of the benefits of becoming a member of the collaborative, that you have access to these resources developed by countries that have already implemented their care plans for dying patients and can be used to help in learning and teaching or quality assurance. And examples here again come from Australia, from UK and other countries involved in the programme. So the international collaborative itself, we have representation of 23 countries from around the globe, and we are delighted with our collaboration with the Indian Association of Palliative Care. We had a kick-off meeting, a foundation programme meeting back in Bangalore a number of years ago, and from that considerable work has been done around developing and implementing the 1040 model in India. We have an executive committee, members of the international collaborative, and then project groups in the key areas of interest. That's the 1040 model, quality assurance, research and development, and education. And underpinning that is international collaborative coordination, which is led out of the palliative care unit here at the University of Liverpool. So we have a number of international collaborative events occurring each year, a research think tank, a webinar series, summer school, and an annual symposium. So the research think tank is an annual online event with the opportunity to share new research ideas and discussions that help to inform future research strategy. So this can be a project that's being developed in one country that may be suitable for international collaboration, or it may be starting to think about the next big project at EU level to help inform and develop research into care for the dying. We have now developed an ongoing webinar series, which is open access. There's a calendar of events here. So for this year, we're looking at advanced care planning. Why would we assist in someone's dying? Dying in the digital age, are you prepared? And a focus on the international collaborative research. For each of these, we have 2 to 3 internationally renowned speakers who do their presentation, and then it's open for discussion from the participants of the webinar. And you, as I say, are all welcome to join us in those webinars. Further information of those can be found on the website. Another development over the past 4 years has been the development of a summer school at Malaga in Spain. Within the summer school, we developed different streams of work of interest within the collaborative. So for members of the collaborative, but also to encourage people who aren't members to come and share their expertise with us about key areas that we wish to take forward into the future. Some of these are around the 1040 model, some around quality assurance, some around research. So the work streams for this summer school in May 2022 are a work stream for the Spanish healthcare professionals around the 1040 model. A facilitators forum. The facilitators are individuals in the countries that are currently working with the 1040 model to share their expertise, to learn from each other. So each isn't reinventing what's already been done in another country. When the facilitators and centres are developing the programme and including a number of different organisations, we have a process by recognising international reference centres. And we have a reference centre based in Norway and Spain. And I'm pleased to announce our first international reference centre has been approved for India. The ILIVE project is around the Work Package 3 volunteer study, which I've already mentioned, and that will bring together volunteer coordinators and leads from the different countries to share the development of the Work Package 3, to look at the research findings so far, and to develop the work plan going forward. Also the Serious Illness Communication Programme, which deals with developing a conversation early in the illness to open up end-of-life care conversations with patients and their families, and again focus on the end-of-life care 1040 model for the Spanish healthcare professionals. Each year we've held an annual symposium, and again this year in October we will hold that in Liverpool. This includes an international conference which people can attend face-to-face, but also attend virtually. Again, these registrations or options are available, and again, you can find those on the website. So why become a member of the International Collaborative? Well, for a very small fee, you can get a reduction in registration fees for our summer school and annual symposium, attendance at the research think tank, secure access to the members section of the website, so access work of the research and project groups, access our quality assurance tools in the 1040 model, and also receive a bi-monthly newsletter. So I do encourage you to visit the website highlighted there and join us in our vision so that we can create a world where all people experience a good death as an integral part of their individual life, supported by the very best personalised care. Here's a sample of the website. Thank you for your attention, and I wish you a very informative and enjoyable conference. Thank you.
Thank you, John. Thank you, Professor Elishaw. I'm sorry, first of all, for joining in late because of the technical problem, which I couldn't help. We are really excited about our Indian Association of Palliative Care membership of the International Collaborative, and it's wonderful to be working with Professor Elishaw and his team in Liverpool and the International Collaborative. And I'm sure this will certainly improve how people are dying in India in the days to come. I'm sure this will be a great benefit for us. So thank you, Professor Alushaw. We'll take the question and answers later. The next speaker is Dr. John O. Heng, who is the HCA Hospice Care Singapore Medical Director. And he has been mainly involved in pediatric palliative care. And he's going to talk about when a child is dying, palliative care when a child is dying. So,
Tech team, can you please? Tech team?
Good evening, colleagues from India and everyone else around the world who is tuning in. It is my pleasure to be part of this awesome meeting. Since this is a pre-recorded presentation, I risk making the wrong assumptions about what Prof. Alushaw may have touched on in his talk before this. I will not be speaking about the care of the dying, the principles of which could be adapted across the ages, but rather specific to the dying child, what dying entails and means, and more importantly, how as healthcare providers we could respond to the phenomenon, thankfully less prevalent than its adult counterpart. The good organizers of this conference has asked me to share my recent work on uncovering what a good death looks like for a child dying from life-shortening conditions. Not unlike its bigger adult cousins, aiming for a good death in palliative care has always been a tacit goal. Never upfront, but always at the back of our minds. You might ask, why is this so? In the varied trajectories that our patients and families go through, uncertainties remain. Things can suddenly turn complicated and life-shorten, whether due to adverse effects of different treatments or as the underlying condition becomes refractory and death anticipated. That is a common situation clinicians practicing in pediatric palliative care or PPC see all the time, especially as we have a predominantly non-cancer population under PPC, and seriously ill children almost universally receive extensive treatments before coming our way. However, we surprisingly know very little what a good death looks like in these terminally ill young persons. Much has been explored and published about notions of a good death in adults by philosophers, social scientists, and clinicians. I share just one here with everyone. Components expounded in that paper by Stenhausen colleagues resonated with me when I first started specialist training. Despite being conducted in a US setting, I see those themes come to life in my daily encounters with patients and families again and again in this part of the world. Quality of their research notwithstanding, what struck me was how common we all are as one humanity, struggling with the same destiny and having exactly the same needs. The other obvious feature that I want to highlight for you here is how when one is dying, the biomedical aspect of care is only one of several priorities among patients, families, and providers as stakeholders. Is the good death construct then generalizable to care of the young person who is seriously ill? That is the area I hope to focus in my brief talk today. Unfortunately, the evidence provided precious little leads. I cite here two pieces of work that are very much congruent with my practice in PPC. A literature review from, again, colleagues in the US and an empirical study from colleagues in Japan. The themes that jumped out at me from the review: social process that is more than just biomedical in nature, many perspectives that must include different stakeholders, and sum of interactions of multiple dimensions and influences, a complex interplay of various factors. Notice, the empirical study already flagged unique factors that are different than the adult version: play, support from peers, and child not being aware of impending death. Given that the review was done in 2008 and early empirical findings from Japan remain tentative, plus they both only apply to children with cancer, there was a need to locate a contemporary yet contextualized construct for a good death in a child who is seriously ill and dying. 8 years ago, I set myself up to conduct an empirical study in Singapore, guided by mentors at the International Observatory on End-of-Life Care in Lancaster University. I started with an updated systematic review, specifically targeting that group of children we see in PPC. The aim is to reconstruct the concept or concepts of a good death for a young person with either cancer or non-cancer diagnoses, soliciting perspectives from different stakeholders, that is, not just a young patient who is dying. Very quickly, these are some of the inclusion criteria and number of papers synthesized. There isn't enough time for us to discuss specific findings here, and you are invited to look up this open access paper to go through in detail if you are interested. A summary of findings, however, is shared in the next slide. I'd like to point out just a few relevant aspects to orientate you before I share findings from the empirical study I conducted next. While each stakeholder, whether it is the patient, family, or healthcare provider, has individually unique perceptions, these perceptions share common themes like needs, experiences, and control. Additionally, these perceptions are colored by structures and processes within the healthcare system where terminal events unfold. The interplay of all three factors listed determines the overall perception of suffering that indirectly indicates the quality of dying or death. Further questions remain after the systematic review, and those form the foundation where the empirical study was designed and built. Again, an open access paper that is freely downloadable from the web. Very easy reading, I assure you. It fulfills my desire to seek reflection and debates on how we could customize care for our young patients when disease-modifying strategies fail and the child is to die. Apart from scholarly contribution to extant evidence, I believe research should contribute to better care of patients and families we are responsible for, and possibly medical professionals we partner with. Declaring here my empirical research question and the theoretical framework and study methodology for those who are curious, please pardon me for skimming through the next few sections on study design in the interest of time. A few pointers on formation of cases, data collection and context. Appreciating the context in particular is most critical in a qualitative study. In this instance, we are interested in events and experiences in the weeks close to death and not just instant before. Infants less than 1 year were not included as their journey is hugely different than those in a general PPC setting. Distinctive to case study design, multiple data sources were included to collect massive amounts of data for deep and extensive analysis. Semi-structured interviews with stakeholders who were also asked to bring or recall items or artifacts that anchored memories of critical experiences, and lastly, different documents were carefully examined, like notes on EMR and advanced care plans that were created. Once again, very briefly, some of the technical bits of data analysis for the academics amongst us. Refer to my theses, again freely available, or peer-reviewed paper mentioned earlier for details. Nonetheless, unique to the case study approach adopted in this study, data was analyzed individually within a case before cross-case comparisons were made. In the end, a summative construct that incorporated all aspects, both universal and peculiar, is rendered. Well, at least that was my aspiration. Now to the findings. 5 cases were finally conceived, stratified across diagnoses, cancer or non-cancer, and whether they had received palliative care. You will notice that they are also spread across place of death, in the home or hospital, and included children of different ages and cognitive abilities. Given the multiple streams of data inputs and the aim to produce thick and rich descriptions, I have attempted to create as many cases as needed for study objectives, which I could manage, of course, at the same time accommodating common case diversity typical in PPC. In fact, 3 of the families came from different countries outside Singapore, including Indonesia, India, and South Africa, who sought treatment at this tertiary hospital for various reasons. I like to think to some extent a cross-cultural perspective was indirectly obtained. 8 common themes were found during data analysis. These applied across the diversity of cases, and I shall go through them with you one by one. Underpinned by the philosophy of critical realism and the theoretical framework of ecological systems, I have organized these 8 themes into 3 domains: antecedents, determinants, and attributes. Letting go is a critical milestone after stakeholders attain emerging insights over time, like frequent admissions, signs of disease progression, assimilating information from different doctors. Only after everyone felt he or she has tried hard enough, thereafter, letting go happens. The motivation behind letting go includes the goal to either reduce suffering or prevent suffering. Reminding everyone here, as an intimate circle around a dying child, not only the parents let go, even the clinicians involved also let go. A slightly varying perspective applies in case 3, however, where the 6-year-old boy with arterial venous malformations lapsed suddenly into a coma in school one day and died within a week despite salvage surgeries. When an outcome is certain and undeniable, like in this case, letting go thus happened a little quicker than the rest. When a young person is first diagnosed with a serious illness, different treatments and social restrictions are imposed, sometimes without seeking assent or even providing information to the child. All participants felt that when the child came to a point of imminent death, the locus of control must shift. There should be autonomy for the child to finally make choices wherever appropriate. Acknowledging the child could also mean making the child feel treasured and loved, especially at this time. This is achieved by parents or providers turning attention now to the child, regarding him or her as a whole person, worthy of himself or herself, celebrating achievements or affirming courage. Closure, close to the end of life, is completed through rituals or legacy-building activities with implicit messages of bidding farewell. This, as practitioners, we are most familiar. What is more interesting, I found, is that closure could also be achieved tacitly through serious conversations about dying and death, drawing families together at a special time rather than an act of separation. Participants all recall these precious and poignant interactions most fondly. Control is very much about mastery over conflicts. So we have moved on to the determinants. In this instance, unfortunately, not everything can be controlled, like the child dying despite all attempts at treatments. This inevitably led to a pervasive sense of helplessness, experienced by stakeholders, both parents and clinicians alike, to varying degrees. Different mitigating strategies were proposed by participants. For example, by shifting control to something else. The mom in case 5 with a toddler dying from leukemia recalled how she channeled her energies to controlling subordinates in her office instead. The parents in case 3 mentioned earlier just surrendered themselves to doctors looking after their boy in the ICU who was soon certified brain dead. Those quick fixes aside, longer-term solutions towards a sense of good death included instead passive resignation to the situation or emotional reconciliation through final acceptance. We now move on to the determinants, systems and processes. During the process of analysis, I found circumstantial elements that included both structural and cultural factors pivotal to the dying experience. These relate to systems and processes within healthcare that influence how care is provided and received. The stability and comfort that results add to the entire experience. Material aspects, the hardware as it were, included, for example, resources in the ICU or availability of a palliative care team. Non-material aspects included personalized oncology care in hospital or compassionate 24/7 support at home. In particular, attitudes among providers were highlighted as most determining. Overall, respect and empathy were the software most appreciated by beneficiaries. The excerpt highlighted in the bubble described how, albeit likely with good intentions, blindly following a convention in EOT to return a personal specimen can go terribly wrong. Lastly, suffering as a determinant. It is not difficult to imagine extent of suffering as determining the quality of dying, but nuances in the interpretation of suffering outside those in the physical dimension were found. In this instance, narratives were somewhat stratified across diagnostic groups. Not living normally relates to the young person not being able to live like peers, enjoying simple play, or attending school. Frequent hospitalizations flagged by the non-cancer group highlights the hidden cost of keeping the child alive for longer, usually neglected until letting go happens. Not having control was previously discussed. The cancer group raised the enduring conflict between expectation of cure and the reality of dying that lies ahead, which led to the sense of helplessness that contributes to suffering. This is a perfect example of how different factors layer and influence each other in a complex interplay within the multidimensional construct of a good death. I shall discuss the last two themes, the attributes of comfort and dying not prolonged, together as they are very much interrelated. Once again, although universally applicable, nuances within these two themes are somewhat stratified across diagnostic groups. Being close to family, with family rendering care, promptly attending to emergent distress and limiting aggressive treatments in the home were flagged by the non-cancer group. On the other hand, management of distressing symptoms was raised by the cancer group. This difference possibly relates to preponderance of pain and other symptoms among children suffering from advanced cancer. I would also like to bring your focus to an aspect that came up among cases where the sick child had mostly died in hospital. The importance of a caring and supportive environment, particularly staff attitudes, once again, that creates a comfort zone, crystallized in a quote from a father of an 11-year-old girl with aggressive mutilating sarcoma, even though she had died at home. In summary, I have constructed a conceptual framework for a good death in a child with life-shortening illness. The proposed configuration assembles its intrinsic attributes, citing causes and conditions that contribute collectively and dynamically to a desired outcome of a good death. As we mentioned before, I hope study findings will enhance understanding and influence practice among those of us who care for a very special group in palliative care. I have come to the end of my presentation. Thank you once again for this opportunity to speak at IAPCON. Best wishes to you all.
Our next speaker is Dr. Eric Finkelstein he's the executive director of this Leon Center for Palliative Care, Duke's National University of Singapore Medical School, Singapore. And we have been hearing about this Leon Foundation Quality of Death Index ever since 2010. And it was the 2010 ranking of India, 40 upon 40, that really spurred us to do something about it. So we are really grateful that Dr. Finkelstein is here to tell us all about it. Thank you, Dr. Finkelstein. Welcome.
Okay, welcome everybody. So I'm going to talk about recent work that my team and I just completed looking at a cross-country comparison of expert assessments of the quality in death and dying. Now, before moving forward, I just want to recognize my team members, including Sushna from India, Prof. Cynthia Go from Singapore, as well as others from Duke and other places. So, okay. Well, okay, so it turns out that everybody wants to be the best, and there's lots of strategies out there to try to quantify who's the best hospital, best city, best employer, best college. I'm probably out of the running for world's greatest dad, but certainly there's a list out there probably for who's the greatest. And it turns out quantifying end of life is no different. The Leanne Foundation, who funds our center, twice before funded the Economist Intelligence Unit, once in 2010 and again in 2015, to look at who's the best country in terms of where you might want to have an end-of-life experience. UK turns out ranked #1 in that one. Poland was 15, and then they ranked up to top 80 countries. I won't comment on whether UK is a great place to live, but according to this reporter, not so great. But best place to die. India, well, India did not do particularly well in the last survey, but importantly, according to this reporter, better than China. So there you go. But my point is, these rankings matter. But I also want to point out that they're flawed. All rankings are flawed. Now, we tried to do something better, and you can decide whether or not we did. But the point is, the prior rankings, including the prior quality of death studies, what they do is they find things that people think are important for a good end of life experience. They come up with some arbitrary weighting factors. Usually some small group of quote unquote experts decides on these things. They hunt around for the best data that they can get on these things. And of course, that's problematic because countries with bad end of life experience probably also have no or bad data. But then they get whatever they can, they do this weighting, and then they assume that those countries that score better are better in terms of end of life experience. Now, the problem is the weights are pretty arbitrary. The indicators may only be weakly correlated with outcomes that matter. So for example, community engagement, some countries may be great. That doesn't necessarily mean that people have a great end of life experience there. For example, maybe they have great community engagement, but no access to morphine, for example, or no subsidies for treatment. So I'm not convinced that this approach is particularly helpful, partly because data availability makes it that the indicators that countries have relied on are only loosely correlated with real end-of-life experience. So for example, they'll look at staffing ratios, doctor-patient ratios in general, not even for palliative care. So who knows? So lots of limitations. So we tried a different approach. So our approach basically relied first on trying to understand what are the core domains for end-of-life care that we think patients really value and caregivers really value. And we did a scoping review. Afsan on our team led that review, and we identified the core domains that we think are most important. And we looked mostly at outputs, not at inputs, because we wanted to measure what matters. So what do patients care about that's measurable? But then we really wanted to understand how can we come up with preference weights for these things that's actionable and meaningful, that's not just based on some small group of experts. And then once we were able to quantify these factors and get them properly weighted, we aim to get data on these things, not from patients, which would have been ideal, but from key informants or experts at the country level who we think could provide information on average for the country. And so that's what we did. So for the first study, the scoping review, Afsan and her team really did a very thoughtful review. They looked at many studies, and basically they came up with 7 domains and 33 subdomains of what patients, caregivers, and others in the health system, doctors and others, thought were important. Now, if you look at what they did, this may be a little bit hard to see, but basically on the right were really input: stewardship and governance, resource generation, access, which to me is an input to outcomes. So poor access would mean poor outcomes. Same with service provision, because if service provision is good, quality of communication, quality of care should also be good. So what we really focused on were the outcome domains of quality of care, quality of communication, and financing, recognizing that if you're good here in quality of communication and quality of care, but you have to spend a lot of money out of pocket, you still may not be too happy. So that allowed us to come up with an initial list of indicators. So what we did in the second publication, also published in the Journal of Pain and Symptom Management, was with input from our advisory board and others, we took Afsan's list and we created 13 what I'll call indicators associated with quality of care, quality of communication, and quality of financing. And I won't go through the entire list here, but just to give you a sense, it extends far beyond, for example, how well was I treated? Did I recover, for example, as you might have in care for non-life limiting illnesses. So information is really important: how you were treated, spiritual needs, contact with friends and family, certainly important in the time of COVID. Communication, quality of the treatment certainly matters, pain management, emotional management, clean and safe spaces, and a few others. Now, we created a list where each indicator was ranked from strongly disagree to strongly agree in terms of how well the care was delivered. And then we used what's called a discrete choice experiment to create preference weights across these 13 indicators and the levels within indicators. Now, I won't go into the details for what a discrete choice experiment is, but basically I would say it's best described as like, would you ever? It's about trade-offs. So would you choose A, would you choose B, based on different scenarios that people are faced with. And the scenarios that we faced, that we asked participants to weigh in on, where we said, okay, suppose you could have a loved one treated with scenario A or scenario B, where the scenarios represented different providers. And then we asked them to choose based on what we showed them. So for example, here's one where we said, okay, you could choose provider A, who ranked 3 stars on healthcare providers encourage contact with family, versus, and then 3 stars in appropriate levels and quality, 5 stars on clean and safe spaces, and 5 stars on ensured patients were cared for and die at their place of choice. Then we said, or provider B or provider C, which was really great on encouraging contacts with friend and family, but only 1 star on these other things. And then the idea is, if we ask enough of these questions, so here is the same sort of thing, different indicators, different stars. If I ask enough questions, I can start to understand the relative trade-offs that you as an individual or a group of individuals would make for, say, going from 1 star in one area to 2 stars or to 5 stars in another area. And so what we did was that I won't go through, here's one more, but we asked about 8 of these questions after designing a survey to 1,250 caregivers of those who lost a loved one within the past 2 years in 5 countries: in India, in Singapore, Kenya, UK, and US. We analyzed the data and we used the results to come up with preference weights using what's called latent class analysis. And I won't go into the details of the methods, But basically, when you look at this, what it shows you is that higher is better, which makes sense. So 5 stars are better than 3 stars, which is better than 1 star. But the length of the line means that that attribute, that factor is more important. So the longest line, it turns out, we're managing pain and discomfort, maybe not surprising, but what may be a little bit surprising is that some of these other things had lines that were only slightly shorter. For example, clean and safe spaces, as well as the quality of treatment, maybe also not surprising, but then clear and timely information. So I won't go into the details of class 2. That was sort of a nutty class whose data was suspect. But in any case, using the class 1 data, which was really good data, we were able to come up with the relative preference rates across the factors or the attributes, and also weights moving from 1 star to 2 to 3 to 5 stars. So basically, we were able to come up with an instrument that we could then assign values or points such that no matter who or how it was somebody filled out our instrument across these 13 indicators, we could score the treatment for that patient or the quality of end-of-life care for that patient. And you can see the full ordering of the attributes here. Managing pain and discomfort, maybe not surprisingly, was number 1. Clean and safe spaces and treated kindly, maybe a bit of a surprise, came up number 2 and 3, not much far behind. And in fact, slightly ahead of the quality of life extending treatment. So clearly, for patients who have life-limiting illnesses, it's not just about quality of treatment. Other things matter. And you can see the full ranking here or the details at the level in the manuscript. Now, I won't go into the details here, but I do want to point out when we analyze the data at the country level, it actually wasn't that different. So there's a bit of variation, but the point is that, you know, people are people and people's preferences really seem to be pretty consistent. They really want to have high quality treatments and they want to avoid pain, but these other factors certainly matter. So I thought that was kind of interesting. So we created that scale, and then what we did was we used that scale in the 3rd manuscript to quantify the quality of life extending treatments at the country level. And to do so, we basically asked key opinion leaders, really palliative care experts within each country that we could identify, or that we could identify respondents, to rate in general, how well do patients fare in your country. Now, the truth is, in the ideal world, we would have actually had real patients or caregivers answer for, you know, in a representative sample, but unfortunately, we just did not have the resources for that. So we did the best we could. We asked key informants, but in the time of COVID, it was hard to get informants from a lot of countries. So we settled on having at least 2 per country in as many countries we could identify, which turned out to be 79 countries plus Taiwan and Hong Kong. And basically, we just asked them to respond for the typical patient in their country for the 13 questions. Tell us whether you strongly disagree up to strongly agree for each of the 13. Then we scored their survey instrument. We ranked them from best to worst, and we assigned a grade from A to F. So you can see a little bit here about the countries. I won't go into detail. This again is in the manuscript, but if you look at the results, just from the unweighted responses from the 181 experts that took our survey, one thing you can see right away is there was variation. So it wasn't like everybody was saying, oh, my country stinks or my country is great. Lots of variation in all 13 questions. When we looked at the transform scores, some countries did very badly, 33.3. Other countries, based on the expert assessments, did really well. And so you can see that distribution here. It's right skewed, but certainly pretty high distribution. But based on our assigned grade cutoffs, only 6 A's, and then a fairly, you know, somewhat even distribution between the B's, but a, you know, certainly sizable number of countries that had a failing grade. Now, when we stratified the data by the overall scores by the income status of the country, what we found was that the high income countries clearly were statistically better, but after that, there wasn't much difference. But interestingly, when you look at why, you can see this is the same sort of information for each of the 13 indicators. For some, there's a clear ordering from like clean and safe from worst, lowest income to highest income country. But in many cases, it was sort of flat, like looking at patient contact. High income is better, but once you get below high income, pretty flat. Same with how well your care was coordinated. But if you look, for example, at costs, what you see is low income countries do very badly in financing. High income countries, mostly with universal healthcare, do much better. So part of the ranking in aggregate is because the low income countries did poorly, relatively poorly on a few, especially the cost attribute. So I won't go into additional details on that. Hopefully you can take a look at the paper, which, by the way, all 3 papers are freely available on the Journal of Pain and Symptom Management website. Here's the full ranking. You can sort of get a sense of the color coding. This is the first 41 with the second on the next page, but basically I won't read the list, only to say that using our very different methodology, UK again came in number 1, followed by Ireland, Taiwan, Australia, Korea, and Costa Rica. That rounded out our top 6. And then you can see here, US, for example, came in only 43rd. So, despite being a high income country, really in the middle of the rankings. And then most of the countries at the bottom tended to be lower income or lower middle income countries. Now, how well does our approach work? Certainly the shortcoming of having only 2 key informants per country is not ideal. That's definitely something we want to improve in the future. But when we compare our scores with the 2015 Economist Intelligence Unit scores, we have an R of about 0.57, so certainly correlated. When we look at our correlation with the Human Development Index, also about 0.54, so correlated there as well. Correlates with per capita GDP, as well as the Palliative Care Development Index, all around between mostly 0.54 in that range. So does that mean it's perfect? Or, I think it means that we're capturing something right, but I also think we bring more than these other indices, so I wouldn't expect the correlation to be perfect. But I do think our approach has many strengths. One is it's very, very transparent, and everything we've done is published. I think it clearly adopts the patient-centered approach, and that's something I think is really important. It's also not limited by data availability. And the truth is, it's great to the extent that it can be applied at the center, region, country, or any level. It can be used to gauge quality across time and to make comparisons across entities. But there's certainly limitations. To me, the main limitation is that in terms of what we did, is that we only had 2 informants per country. I would love to have more, and hopefully that's something we can overcome in the future. And if you have ideas on that, definitely let me know, shoot me an email. It's not a validated patient-reported experience measure, but we are certainly working to overcome that as well. I have a study ongoing in Singapore to try to use it as such, and so that work is ongoing. And I do think those limitations can certainly be overcome. There are some other concerns about reporting heterogeneity I won't go into, but we did include vignette questions in the survey that we can then use for adjusting and correcting for self-report bias. So that work is ongoing. So, I think if I were to conclude, I would say EOL experience, end-of-life experience, is certainly bad for many people in many countries. I think measuring quality is really critical for trying to improve it. I think we provide a reasonable strategy that hopefully can be improved in future efforts. And I would argue, Peter Drucker, famous business guy, says you can't improve what you don't measure. So I think measuring EOL or end-of-life performance is really crucial. And I think we provide a neat approach that can be used either as a substitute or complement to prior approaches. And I certainly hope that you guys will find this interesting. And if you want to try to discuss how we can do more with this, please let me know. Again, I want to thank both my colleagues as well as the Leanne Foundation for making this possible. And I would encourage those who are interested to visit our website, where you can see detailed data at the country level as well as all of the manuscripts and materials we use to produce this work. Thank you very much.
Thank you, Eric. I congratulate all the speakers, Professor John Ellerso, Eric, as well as Dr. Paul. The good debt is very much needed, and we are optimistic. The palliative care is growing in our country, and in the coming days we need to develop more of the systems in place so that we can offer a good quality end of life care. Now the global community has come up with a lot of resources, as we can see here today, that our leadership are also involved. The IAPC is also involved in formulating a good strategy for end of life care. So I think that this session has benefited to all of us, and in due course it is important that we need to implement this thing in our palliative care centers in the coming days. That is very, very important. And to Professor John Ellerso, I was wondering actually whether this 1040 model, it can be applied in community setting as well.
Yeah, thanks, Dinesh. Yes, so the 1040 model has been used to guide care in the community setting. What the 1040 model does is has outcomes of care for care for the dying. So that can be within a hospice setting, hospital setting, or community setting. So
Okay.
The plan of care and the documentation is developed locally to suit the local environment and needs. Yeah.
Yeah. So thank you for that. And as John has already said, these documents are available freely, so we can use this document for our benefit, isn't it?
Yes, and there's kind of work ongoing in India at the moment around these documents and adapting them for use in India.
Thank you.
I think we'll have to stop because we have run out of time now.
Okay. So there is no any question in the chat box. So I think concluding remark you can have, Dr. Stanley.
No, that's all. I just want to thank both Professor Ellershaw and Dr. Finkelstein for telling us so much that how we can improve things in India. Thank you.
Thank you so much for joining us for a very interesting session. The next session will start shortly.